Okay, so we'll go on here and talk about inflammatory lesions. We'll talk about osteomyelitis, a diabetic foot, foreign body, systemic sclerosis, and then about arthritis. So, Ashley, what do you think of this case?
All right, I think we're looking at the third distal metatarsal here.
Right.
Looks like there's a lot of low signal there. I don't know if there's a soft tissue ulceration there.
Oh, sorry about that. Okay.
I'd be worried, based on the history, there might also be some sarcoid. There seems to be a lot of degenerative disease of the first digit. I don't know if this patient is a diabetic, could have some Charcot-arthropathy, and then this could be concerning for osteomyelitis.
Yeah, that's exactly what this was, and there was an ulcer here, and this was a direct extension of infection into the soft tissues at the ulcer into the distal third metatarsal head, and very typical of how osteomyelitis can start out, especially in diabetics in this area. Jennifer, what do you think of this case?
Okay, so here it looks like there's an ossific fragment along the distal Achilles tendon. Looks like an ossific avulsion injury of the distal Achilles, and there's surrounding edema and fluid signal intensity. I don't see any discrete overlying ulcer.
Okay. Here's the post-contrast. What do you think of the post-contrast views on the right?
Okay, well, if we compare it to the middle image, it looks like there might be some enhancement of that effusion in the posterior subtalar joint. So I wonder if this could be infectious or inflammatory.
And notice there's a lot of edema in the calcaneus. This is someone who had calcaneal osteomyelitis, and it weakened the bone so much that then you got really a fracture of the calcaneus and avulsion of the Achilles tendon with a little bit bone fragment coming off there. So this is another case of osteomyelitis and showing some of the complications you can get with osteomyelitis. Michael, what do you think of this case?
Okay, so we have a lot of soft tissue swelling over. Looks kind of weird in the orientation I'm looking at. It's not like the distal fibula I'm looking at.
Yeah, this is the distal fibula here.
Yeah, it just looks like a little, yeah, it's got a chunk missing out of it, kind of a cortical defect, a lot of edema. And I mean, I'd be concerned that there's like soft tissue ulceration and osteomyelitis.
Here are the coronal images.
Yeah, and you just see, extensive soft tissue inflammation and the, it's pretty T1 dark, indistinct. You can't see the cortex, so it'd be osteomyelitis.
Right, exactly. Another osteomyelitis. Ashley, what do you think of this one? This is on 6/16/08.
All right, so here we have some low T1 signal, poor cortical margins of the proximal phalanx of the first digit with increased T2 signal. Some concerning for early osteomyelitis.
Okay, this is on 6/16/08. And there it is again, 6/16/08. Mm-hmm. And here's 9/17/08.
Well, now you can see it's progressed into the proximal aspect and of the first, sorry, the distal aspect of the first metatarsal, and this could be early septic arthritis as well. And it's progressing also along the second and third metatarsals distally.
Okay. Here's 6/16/08. Patient.
Yep. Okay. Oh, and then patient. They had an amputation, I'm guessing.
Right.
And then it recurred.
Yeah,
and then it recurred.
And extended and expanded more proximally. And this is a problem that you can really have with diabetics, is you can just kind of start chopping off and not know when to stop. So it's important that you get all of the infection on the first surgery, and that it's the skin is meticulously maintained so they don't get reinfected. So this actually shows osteomyelitis of the distal second and third metatarsal heads, and probably some early Charcot development of the midfoot. But you'd have to be very concerned that you couldn't rule out infection involving the cuneiforms as well in a case like this. So this was an amputation, and then with further progression of the disease. Jennifer.
Okay, so I think we're looking at the distal tibia here, and there's extensive osseous erosion along the distal tibia. I don't see the rest of the midfoot very well, so I wonder if there's either chronic subluxation or there's just diffuse destruction and increased signal throughout the midfoot. This could be extensive advanced Charcot neuropathy, or it could also be osteomyelitis if they're diabetic. There's some enhancing joint effusion as well, that rim enhancement.
At least and above, what's your aspect of the tibia?
Yes, there's a fluid collection. I'm not sure where that's extending from, if that's myositis or...
Yeah, this was a diabetic, and this was all infection, and these were all abscesses. Where you can see.
Well, what happens not infrequently in the old days, maybe even today, the amputation is done not proximal enough. I never did that. I did a BK amputation almost exclusively. I didn't try to save tissue because I've seen too many of these kind of things happen, and then you wind up amputating every 3 or 4 inches, and that just doesn't work too good. BK was I hated amputations, but BK was the best for these folks.
Thanks, John.
Because they were, you usually still had pretty good circulation below the knee.
Here's just another example of a diabetic foot with extensive abscesses that you can see. There was a time when people were reluctant to give contrast to patients with diabetic foot because they're concerned about renal disease. But with the current agents that we use, the risk of renal disease is insignificant compared to the value of the information that we get giving contrast, because you really need the contrast in order to really see where the abscesses are. And as John was saying, you have to get rid of all the infection if you're going to operate. Otherwise, you're just making matters worse. So contrast really is very valuable in pre-surgical evaluation of these patients with diabetic foot. Michael.
Okay, so 73-year-old male, diabetic with 6-month history of heel pain. So on the STIR sequence, we see a lot of edema in that posterior calcaneus and the visualized soft tissues. On the T1 weighted imaging, the cortex is incredibly indistinct, and then there's dark too. So that's concerning for. And I think is that actually maybe few foci are like gas bubbles, that kind of those stipulations as hypointensities.
Okay.
So you have osteomyelitis with maybe like some gas forming. Yeah, that looks like gas forming bacteria.
Back in here. Yeah, and that was. It turned out in this particular case, this was a sinus tract, and this probably wasn't.
That might just be tracking in from the outside then.
Probably tracking in through the sinus tract, but that's important to notice. Thank you, John.
Gas formers not very common in diabetics for some reason. I don't remember seeing any that I can recall.
Okay, interesting.
I don't know how many you've seen, John, but most of the cases I've seen was staph or strep.
Yeah.
Or Pseudomonas. It wasn't. It was a usual organism, not the stranger.
This is a
That's
patient.
a foreign body.
Yeah, this was a patient who had chronic foot pain, and she was an avid gardener. But she's had foot pain, I think, over a series of months. And they'd treat it with antibiotics. It would get better. They'd stop the antibiotics, and then it would start hurting again.
Is this for me?
Yep.
Looks like there is a focal increase signal both within the third metatarsal and also in the fourth metatarsal. I don't know if there's some low signal internally of that fourth metatarsal. Could there be a foreign body? Also along the plantar aspect of the fourth metatarsal, there's some increased signal as well.
Yeah, right in through there. So what do you think this little black thing is?
Yeah, I don't know what it could. It be like some type of foreign body, like a thorn or something that she stepped on, or
Yeah, she had a lot of palm trees in her yard, and when they grow down, those they have about 3 or 4 inch thorns, and she actually stepped on it. It broke off. They thought they got it out, but this was a residual foreign body, which you can see actually went all the way into the bone there. And of course, once they saw that and got rid of the foreign body, then they were able to cure her infection. Jennifer.
We have a 52-year-old physician's wife with recurrent foot pain when taken off antibiotics.
And this patient basically had the same history as the prior patient, and
I
actually
see.
they lived about a mile away from each other.
Okay, so again, there is some edema, and it looks like a foci of low signal there. I think this is the dorsolateral aspect of the foot, and that's concerning for a foreign body. It could be another thorn. Here we can see a linear foreign body.
Yeah, another palm thorn in the foot. Another time when we get a lot of foreign bodies in the feet are after earthquakes. Because very often with earthquakes, glass will break. People will get up out of bed and not have shoes to wear, and they'll walk across the floor and cut themselves on the glass because they can't see where the glass is on the floor. So it's always recommended if you're in earthquake country to make sure you've got a pair of slippers next to the bed in case you have to get up and walk in the night to keep you from getting cut by broken glass. And this, John?
What I wanted to say, John, is if you look at these foreign bodies, the thorns, they're usually horizontal.
Okay.
People don't step on these; they kick them.
Okay.
They kick the palm frond
Out of the way.
and a thorn sticks into their foot. So and it's kind of so.
Interesting.
Now that we can see them on MRI, it's not that difficult to locate. But in the old days, on X-ray and so on, digging for these was a miserable thing to do.
Yeah.
It was.
Right.
It wasn't fun at all.
Mm-hmm. Michael, what do you think of this case?
Okay, so it looks like we have a soft tissue defect, on the plantar aspect of the foot with like a sinus tract or something. It looks like there's some signal in there. I don't know if there's like a foreign body like the other cases. And then, that's what it looks like on the axial image. So
What about the shape?
I don't know if that's just volume averaging of that MTP joint.
So this is a piece of glass.
Got it.
So if you guys are around here when there's an earthquake, this is what glass tends to look like on an MR scanner.
My advice: wear slippers, whether there is an earthquake or not.
So as you know, with plain films, you couldn't see the glass unless it was leaded glass. So they have to be very wealthy individuals before you'd see the glass. And most people who did not have leaded glass around, the glass was pretty invisible to x-rays. But with MR, both give defects here because there's no water inside the glass, so it comes across as being black. Okay, Ashu.
This actually looks like a pediatric patient. I see fusion along the anterior physis of the tibia and a lot of edema there, kind of spanning that metaphysis and epiphysis. It looks this, and there's some soft tissue edema as well. You know, I'd be worried about like a Brody's abscess.
Good. Yeah, it's a very typical appearance of a Brody's abscess. Starts in the metaphysis, and then when it gets large enough, it can extend through the growth plate. Yeah, usually we catch these before they extend through. John?
Yeah, it's kind of sad that they wait that long.
Right.
Obviously, this was present much longer than it should have been.
Right. Jennifer.
Okay, so 48-year-old female with intermittent left ankle pain for 5 years. So here we can see a radiograph. There may be some lucency along that distal fibula. It's hard to tell on one view only. And then also we have a bone scan, and there is a little bit of asymmetric uptake there along the distal fibula. Could be infectious. So here we can see a rounded stir hyperintense area along the distal fibula, and there's kind of some cortical irregularity in that region. This could be a chronic infection. Okay.
Yeah. This tended to be an abscess, and it's primarily in the cortices of the bone, intercortical abscess. Okay. Michael.
Okay, so you know, there's significant abnormality around that. I don't know which phalanx we're on. Around that proximal phalanx, right there of the 4th digit, and then there's some hypointense, I think probably loose bodies in the soft tissues. So I was wondering, and then there's like, I don't know if this is a foreign body with like reaction and infection.
This was an infected joint. It spread into the adjacent bones. So this was osteomyelitis that started out as a joint infection. Okay, Ashu?
Right, so adult with increasing second metatarsal pain rule out Freiberg's infarction, and it looks like there's actually significant low T1 signal, poor cortical margins of the distal second metatarsal, as well as the proximal and intermediate phalanx of the 2nd digit there, and a lot of soft tissue edema. I don't know if those are fluid collections or abscesses there as well. I see some low signal foci, which may be gas or foreign bodies. This looks concerning for osteomyelitis and septic joint to me.
Yeah, and that's what this was. So this wasn't a typical Freiberg's infraction, which would just be involved the metatarsal head. We can see that there was a fusion in the joint space and edema both in the soft tissues as well as in the proximal phalanx. And so it's really on either side of the joint space. So this is really an infected joint with secondary osteomyelitis, and not just trauma.
Can you go back for a second? Is that skin kind of quite thick, or maybe there was an ulcer there?
Or down here?
Not an ulcer, but a callus.
I'm not sure, John.
I'm sorry. Forget what I just said.
Okay.
I was looking at that tendon.
Okay.
Wake me up.
Jennifer, foot pain.
Okay. So there is absence of the distal aspect of the 5th digit. It looks like they may have had prior amputation of that digit, but now that there's decreased T1 signal intensity within the remaining 5th metatarsal with edema, and there's an adjacent fluid collection in the plantar subcutaneous tissue. So this is probably an abscess and osteomyelitis.
Good. Yep. Michael.
Okay, so we have a lot of edema involving that talus and some cortical irregularity along the medial aspect. So going along with anything worried about, infection.
Right. I guess it could be trauma, but
yeah, if they have a history of
have
trauma.
to look other things well. But this is kind of a diffuse marrow edema pattern, and the subchondral bone looks like it's pretty intact. It just looks like you got destruction of the underlying trabecular bone here. And again, this could be trauma, but it turns out in this particular case, this was talar osteonecrosis that then extended into the joint space. Okay, Ashu.
Looks like there's a periosteal reaction along the posterior aspect of the tibia here. There could be a hematoma, or it could just be, given that there's so much soft tissue inflammation, and there's also a lot of marrow edema and irregular signal throughout the tibia that we can see, it could just be that there's a subperiosteal abscess there. Yeah.
Yeah. So this certainly could be trauma, and this could be as hematoma and the subperiosteal hematoma. But this kind of pattern doesn't look typical of trauma. You'd almost think that maybe there's a double line sign, but I wouldn't. I kind of think it could possibly be an infarct, but it just is too uniformly involving the marrow space to be a typical infarct. And this turned out to all be infection with Staph aureus.
Dirty looking.
Yeah, right. Okay, Jennifer.
Okay, so we have increased pain and swelling at night or on the right heel since a dog bite 3 years ago, and there is some soft tissue gas in the plantar fat pad adjacent to the calcaneus. It almost looks like there's a tract extending to the calcaneus, and then there's a lucent region in the calcaneus. I think this is suspicious for osteomyelitis. Here we can see that tract of abnormal signal extending to the calcaneus and fluid within the calcaneus with debris compatible with an abscess.
Yeah, and probably gas in it as well. Yeah. But it's an open sinus tract, so the gas probably came from the outside. Yeah, so this was a typical sinus. Okay, Michael.
Syndrome of female heel pain. So we see some irregularity involving that plantar aspect of the calcaneus. On the kind of axial images, it looks like there's some irregular lucency with ill-defined borders. So you'd be worried about get an MRI. So in the MRI, we see ill-defined cortex, kind of edema through. I'm wondering if there's on the post-contrast images, it's kind of peripheral, like rim enhancing, like those almost look like fluid collections.
Okay.
So I'd be worried about intraosseous abscess.
What would you do with it?
I would let the orthopedic surgeon know.
That's
I guess this has turned out to be TB osteomyelitis, so this can be like a low-grade, kind of a smoldering infection, most likely.
Yeah, well, with TB, you do antibiotic treatment.
Yeah.
Whatever kind you need. But if this was a staph infection and you had to remove the tissue, in this case, you might have to also, but maybe the Breedman would do it. But with osteo and so on, you're kind of in a hurry to remove this stuff. What you do is do a longitudinal incision and unpack it with gauze or whatever you have available, and keep it draining until it heals. The problem with the heal, though, is that the healing is poor. So you sometimes will wind up with 2 heals rather than 1. If you're going to get an infection, this is one area where you don't want to get it.
Okay, thank you, John. Okay, Ashu.
All right, so here, especially on the posterior the sagittal radiograph, I could see some gas, I believe, within the posterior soft tissues, and I don't know if there's a lucency within the distal fibula as well. Right there, yeah, I'd be worried about, there's some irregularity. The talus also, I don't see the margin of the anterior talar margin very well. There might be, I'd like an MRI on this to see what's going on. Looks like there's a lot of a big, I don't know, is that within the muscle or no? Soleus? No, that just looks like there's an abscess there, soft tissue abscess, extending from the joint. It's enhancing, and there's a lot of edema of the talus and tibial plafond posteriorly. I'd be worried about early osteo, and you can see some erosions too on the T1. Yeah, and also of the fibula. That lucency on the radiograph is much clearer on the MRI.
What do you think the organism is?
I'm guessing it's it could be staph. Or, okay, it's TB.
Well,
okay.
Actually, it's probably not staph. Staph would be much more destructive than this. So this is a lot of involvement. You've got a large fluid collection here, and there are some erosions, but you're not seeing really gross destruction of the joint. If this were staph or strep, especially staph, and this has been around for months, you'd see much more destruction. And when you have these large, what are called cold abscesses, that really makes you think TB. And as you know, in the spine, you can get these big abscesses that can span 4 or 5 different vertebral body levels. And that's very characteristic of tuberculosis because staph or strep, a typical bacterium that we normally see these days around here, is much more aggressive than that and will have much more destruction by the time you had this much fluid.
Especially if it's blood-borne and you have septicemia. That's you don't last very long.
Right. Okay, Jennifer.
Yes, we have an 8-year-old female with right ankle pain for 2 weeks. And we can see there are some lucent lesions in that distal metaphyseal region of the tibia, and also some irregularity of that anterior epiphysis that looks like suspicious for extension. So I'm concerned about a Brody abscess or intraosseous abscess. Here we can see that there's edema there in the distal metaphysis and extension through to the epiphysis with some cortical disruption and tibiotalar joint effusion. This is concerning for infection and probably an infected joint as well.
Right, which is what it was. And this again was TB. Michael.
Okay, 27-year-old female. Asian travel, ankle pain, and swelling. There might be some soft tissue. So I'm looking at the bones. I'm not sure I'm seeing too much on the bones. Yeah, and kind of where we're seeing the soft tissue swelling looks to be like an ankle joint effusion that's pretty heterogeneous with some synovial thickening. And so, I'm worried kind of like about like a septic joint, and there's also, I guess, soft tissue infiltration posteriorly.
Yeah.
And so, yeah, like this looks like just diffuse synovial thickening, so something causing a synovitis.
Yeah, and this was atypical mycobacteria, which caused this. I think it was avium.
So back on those first images, was that actually any joint effusion at all, or was that just all synovial thickening?
This is all synovial thickening, but
Yeah.
I'd call it joint effusion as well. Yeah, well, maybe there's some, but most of it's synovial thickening. This is all synovial thickening back here. And that was atypical mycobacteria. Okay, Ashu.
All right, so we can see a lucent lesion in the medial distal tibia, and it looks like there is a cortical break on the CT. I don't see good cortex spanning that. There's some increased sclerosis along the edges. This looks like progressing, and then there's also some erosions a little bit more distally within the midfoot at the navicular, and so just kind of diffusely abnormal. So this looks like an atypical infection.
Yeah. Okay. Jennifer.
Okay. So here we can see osseous erosions along the subtalar joint, and also in the anterior process of the calcaneus, there's large osseous erosions and a subtalar joint effusion, and also a talonavicular joint effusion. This most likely is an infectious osteomyelitis. It could be atypical as well.
Yeah, this happened to be cocci. This was here in California, and notice it's you're really obliterating the sinus tarsi here. So a lot of erosive changes, and then a lot of synovial thickening and ill-defined bone marrow edema, and this was all coccidiomycosis. Okay, Michael.
Ankle pain in an AIDS patient. So we see all this kind of patchy, hyperintense signal, kind of linear in the distal tibia and all throughout the talus. So I'm worried about some kind of opportunistic infection. I mean, it almost looks like, in a way, like almost looks like kind of like infarcts would look, but I don't think it's that exact look. So I'd be worried about some other weird atypical type infection, like I don't know, I haven't really heard. Oh, so they are infarcts, okay.
Yeah, these turn out to be all bone infarcts because they can get a vascular
is
disease.
that like, okay.
They get a vasculitis and they get bone infarcts.
Using the word weird can get you in trouble nowadays.
Right. Yeah, so these are all bone infarcts. Good that you brought that up, Michael. Okay, Ashu.
Okay. Bone scan. There seems to be uptake within the tibia on the left. Patchy areas, and also within the clavicles on the right side, and a little bit of the ischial, maybe the pubic ramus on the left side, and I think we're looking at the sternum here, and
the maxilla.
Yeah. Oh, and then there's patchy uptake also at the calvarium. Kind of diffuse. Wow. Okay. So you see a little bit of, a lot of edema of the diaphysis of the left tibia, and there might be even some significant soft tissue edema along the medial aspect. It looks like there is within the cortical margin, there is is that a fluid? Oh, is that enhancing? Yeah, I think it's kind of
not enhancing much. This is
not enhancing. There's a lot of soft tissue enhancement. A lot of soft tissue enhancement. So okay, syphilis.
Yeah. So actually, sexually communicated disease are on the real upswing these days. So it's going to be something that you may well see. Okay, Jennifer, normal or abnormal?
Okay, so persistent postoperative pain. Here I can't see, well, actually I do see some hardware tracks in the distal fibula, so they probably had a prior fracture in this region, and there's irregularity of that fibular diaphysis, and there's just diffuse increased signal within the distal tibia, fibula, talus, and the superior calcaneus, and enhancing There's rim enhancement throughout the marrow and enhancing joint effusions. Most likely this may be infectious could be from a prior open fracture or after surgery, post-op osteomyelitis.
Yeah, so they went in and put in internal fixation, and that got infected, and they had to go remove the fixation.
The thing about that is I don't see any signs of internal fixation screw holes. The thing is, if you get an infection, you don't remove the hardware unless you absolutely have to. You treat it with the hardware in place as long as you possibly can to try to cure it. Once you remove the hardware, you don't have stability, and the infection will just increase. There's no way to stop it. So hardware is something you just do not remove. If they had some kind of surgery here, I don't see any signs of it.
Here are the screw holes in the fibula, John.
That may be a couple of screws that went in to stabilize the fibula to the tibia because it's a high ankle fracture, but I'm not sure that started the thing.
Yeah, they put a plate in and they went in and removed all the hardware in this patient.
If they did, that was not something that I would have recommended. That's for sure.
Okay. Yeah.
You see the results. What are you going to do now?
Yeah, it was a real problem.
It's amputation time.
Yeah. I don't remember what they did later, but that was all post-op osteomyelitis.
My prediction would be that they did a BK or maybe even further.
Okay. Let's see. Michael, what do you think of this one?
So there's a kind of a regular soft tissue collection in the plantar subcutaneous fat underlying the calcaneus. It doesn't look to go very deep, so probably just like a non-specific fluid collection, could be infectious, like phlegmon or abscess.
Yeah, this was a subcutaneous abscess. Okay. Ashu?
Sorry, could you orient me here? Where are we exactly?
So here's a marker here. Here's the
okay, that's a fibula.
Okay. There.
Okay. Looks like okay, the skin marker is along the medial aspect of the high ankle, and we can see that there's actually a little bit more distal to that. There seems to be a heterogeneous soft tissue collection superficially, so I'd be worried about a superficial abscess there. A lot of inflammation. Is there some hardware there? Some hardware posteriorly near the Achilles.
Yeah.
And then there's an abscess kind of spanning near that with a small track. So.
Yeah, this person also had surgery for Achilles repair and got infected after surgery. Okay, Jennifer, 76-year-old female with calf pain and swelling, and they're concerned about DVT.
Okay, so here we have an ultrasound of the calf, and it looks like there's a fluid collection with a linear low signal intensity material.
Acrogenicity?
Yes, it's not compressing. I guess we should probably look at the vascular flow to make sure this isn't sequela of a chronic DVT. Here they put a measurement on this hypoechoic region, and I'm not sure what we're looking at here. It looks like there are some internal echoes.
Yeah, there's not much flow in it.
Okay, so there's not much flow.
This
could be like a superficial thrombophlebitis. Hematoma was drained, pain and swelling after drainage.
Yeah. So actually, this really isn't a vein.
Oh, it's not. Okay.
that's a collection, fluid collection. And then they went in, it was a hematoma, they drained it. This is a 1/29/2010. See, there's a lot of gas in it at this point.
Yes. Okay, so there's an increased side of the fluid collection and gas locules compatible with an abscess.
Yeah, so this ended up being an infected hematoma, and they had trouble really getting it drained, and that finally did. Okay, here's Michael. Here's a patient who had a surgery for Achilles tendon rupture, and twice before now came in with increasing pain and redness in the area of the surgery.
Okay, so two-part Achilles surgery. So we see a lot of edema and soft tissue irregularity, and foci are probably a micrometallic artifact in the region of the Achilles, which doesn't appear to be in continuity.
Okay.
And there's a inference screw right there. I don't know if that's kind of protruding a little probably, and there's some signal below it, but I don't know if that looks infected or not. And now we see that there's this rim enhancing fluid collection. So, you're worried about a big abscess right there, phlegmon.
Yeah, so that was a PostOp abscess from infection. Good. Ask you.
All right, so 28-year-old male with increasing big toe pain and swelling for 2 years, nail pitting. You can see at the, this doesn't seem to be coil artifact. There seems to be increased signal of the distal phalanx of the first digit, and then there's also a lot of, I think there's actually superficial fluid collections there along the medial aspect of the distal phalanx. And there's edemas extending along the plantar aspect as well. It might even involve that flexor tendon. And there's a big joint effusion, or there seems to be a lot of, is that at the nail bed?
Yeah,
like,
it's a subungual right here.
Yeah, subungual abscess.
And this is all a fungal infection of the nail bed. Something that's not too uncommon, especially in the South, the deep South of the U.S., where it stays humid a lot. And these can be very difficult to treat.
Jungle.
Yeah, jungle. Jennifer, slow-growing mass for 2 years.
Okay, so we can see this ill-defined hypointense mass-like region along the intrinsic foot musculature near the level of the metatarsals.
With these kind of funny ray-like low signal intensity areas. And here are the coronal images. This is the involved side. This is the normal side.
Okay, so it's heterogeneous and there's this low signal intensity.
This is PD, this is T2.
Yes, PD and T2. Okay, so on the T2, I don't really see much fluid signal intensity. It does look the same signal intensity as the adjacent musculature or soft tissue.
And this patient does have a draining sinus, and there are these little yellowish granules that come out of it. A lot of people call them sulfur granules.
Okay, so this is a chronic infection, actinomycosis. Yes.
Yeah, so this is chronic actinomycosis. Yeah. Okay,
Almost like more fibromatosis at the end.
Yeah, it looks all like it could be, but it had a draining sinus.
What happens is people cut the callus too close to where they shouldn't be and get infected.
Michael.
Okay, so it looks, I don't know if it's in the soft tissue, it actually looks centered within the aspect of the calcaneus. There's all these kind of hyperintense rim with central hypointensity nodularities within the bone. It's probably some kind of weird, or sorry, I shouldn't say weird. This is like a fungal type infection.
Yeah, it's a little bit off to the side. There's the lip of the calcaneus.
This is the only way you can tell it's a calcaneus.
Yeah.
That was just a mass on that other imaging.
Yeah. And this was a fungal infection of the calcaneus and extending out into the soft tissues, right?
You wait a while, it won't be there.
Yeah. And when it becomes bad, it's called the Madura foot, where you get a suppurative infection.
One ugly entity if you look at it clinically.
Say that again, John.
It's a very ugly entity if you look at it clinically.
Yeah.
Worse than on MRI.
Yeah. You can get it from actinomycosis. It's a chronic, slowly progressing infection, but most of the time it's going to be fungal. But often it's super infected by other organisms as well. But it's primarily either actinomycosis or fungal. And this dot and circle sign is pretty specific for Madura foot. Okay, Ashu.
Okay. So a 29-year-old male with foot pain, starting at the area of the navicular and extending distally. I do not see a normal foot. I don't know if this patient has had prior amputation and infection. Yeah, it looks like status post transmetatarsal amputation and chronic pain and wounds. There's a lot of erosions also, I think, of whatever's left of the midfoot, which may be from prior infection and or a current infection. Looks like there's the axial T1 sequences. We can see a sinus tract extending into the foot with significant edema seen on the axial sequences. Similarly, on the STIR images, you can see a lot of edema, and I don't know if those are heterogeneous fluid collections or abscesses there. It looks like those are abscesses clearly on the post-contrast T1, and they're restricted to oh, that's how the foot looks. Okay.
That's kind of what the Madura foot looks like. Right there, it's ugly.
Yep.
I guess that's what it is.
Yeah. Jennifer.
Okay, so we have a 10-year-old male. We have 9 months ago his left calf, and he has known AML treated for 1 year. So here we can see this intermediate T1 signal intensity region in the tibia that demonstrates some enhancement on the post-contrast images and increased signal on the T2 images. This could be involvement from known AML, or it could be treated AML. And then now we're looking at the contralateral calf 9 months later, and we can see this kind of mixed echogenicity oval collection along the left calf. Looks like it may be intramuscular, and there's really no intrinsic vascular flow, but there's some surrounding peripheral vascularity. Okay, so
Yeah,
aspergillosis.
This is aspergillosis.
Anybody with that.
Is this an infection of the muscle then?
Yes. So this was this was osteo at this time, but it's hard to get rid of it systemically, and then this is actually now in the muscle.
I'm trying to kind of make a joke out of it. Anybody knows it's aspergillosis, not coccidio or something.
Yeah. Okay. And
So is this a fungus ball?
yeah.
Like, I guess
That's
it's showing 1 week
infection.
later.
If I was going to dictate that report, I'd say consistent with a fungus.
Yeah,
Yes, can we rule out involvement of his known AML or?
Well, I don't think you'd see AML as a mass within the muscle like that, and it's usually not this focal in the bones. So you have to be concerned, and they can get infected by unusual organisms. So a lot of these, especially, a lot of these have to be worked up. And obviously, this was biopsied, and they grew out aspergillosis. That's how they made the diagnosis.
Probably not in America, I don't think.
No, that was
What do you think?
South Korea.
Yeah, there you
Okay.
go.
Michael, what
And
is
just
this
multiply that times 10 in North Korea.
patient? Right. I don't remember the history on this patient, Michael.
Okay. Well, first thing I notice is kind of this, there's elliptical increased stir signal right there in the superficial soft tissues, and it's very low signal on the T1. It doesn't look like it goes to the muscles. You know, it kind of looks like either they had an injury there. I mean, it could be,
Sure.
I guess, soft tissue infection.
Yeah. So it could be an injury. And then notice we have
And then I guess you're trying, there's kind of a rim of the superficial edema, which could be like a cellulitis or the systemic fibrosis.
this turns out to be a systemic fibrosis.
I've never seen that.
Where you're thinking about.
Yeah. Well, where we saw a little bit of this in MR was when people in renal failure got high dose of the old gadolinium antibiotics. I'm not contrast agents, and you could get a fibrosis in this. That's what this is. This is actually gadolinium reaction. Okay. Ashu.
Looks like a lot of soft tissue erosions at the the tarsal metatarsal joints, as well as at the first distal metatarsal.
Bone erosions.
Soft tissue erosions.
Hello? Can you?
Just said soft tissue erosions.
I think so.
That's not soft tissue, that's bone erosion.
Oh, soft tissue eroding into bone. Sorry.
Okay, I was just a little confused there.
I
mean, I'm easily confused, you know.
Yeah.
John can tell you that.
No, that's not true. So this is a patient who had known rheumatoid arthritis, and you can see these multiple erosions and the synovial thickening associated with the erosive disease. Jennifer.
Okay, so we have a 58-year-old female with progressive pain, swelling, rigid second hammer toe, and second MTP cyst on X-ray. It does look like she has some erosive changes along that second metatarsal head.
Some soft tissue thickening there.
Okay, so, and also along the fifth metatarsal head with surrounding edema. This could also be inflammatory arthropathy. This here again, we can see some synovial thickening surrounding that MTP joint. I guess this could also be rheumatoid arthritis. And her symptoms persist, yes.
Yeah, so it's rheumatoid. And here you can see the osteitis in the bones. Okay, Michael.
Okay, so 67-year-old female with RA and palpable lump. So we see this kind of mildly heterogeneous, but overall kind of intermediate low signal density mass right inferior to the first kind of MCP. And if she has known rheumatoid, I don't know, you could worry like a rheumatoid type nodule. It doesn't look to be affecting the actual tendon itself.
So they removed this.
Just a big synovial thickening.
Yeah, this was a big rheumatoid nodule.
Hey, I'm getting a phone call. Sorry, real quick.
Okay. Well, actually, why don't we stop here? and we'll pick back up tomorrow, okay?
Great, thank you.
Thanks.